nutritional requirements of pediatric patients with gastrointestinal involvement. Just a word of caution. Uh, Children have different disorders as compared to adults, and children cannot be considered as little adults. So our requirements are little different: fluid management, caloric management, protein. There are things that an adult has restrictions where children don't have. So with that, we'll start with the assessment parameters. The assessment parameters, normally we look from head to toe in terms of nutrition. We look whether the children have vitamin deficiencies, whether they have any stigmata of any other illnesses. And clinical examination makes a very big importance to whether a child is nutritionally proper or not. We look at the fat thickness, things like that. Weight and height, best in today's world is to use the Z scores for academic purposes, but also it's important with the growth charts to look at the linear growth. Body mass index becomes a very important assessment of nutrition over a long time. So weight gives you a immediate assessment, and height tells you that the patient has been short for a very long time. Mid-arm circumference is very good for field purposes. Waist to hip circumferences are good for obesity. Triceps fold thickness again for obesity as well as malnutrition. Then you have biochemical parameters that indicate nutritional adequacy, such as albumin, calcium, vitamin D, bone mineral density. And now they are also looking at the psoas muscle, the CT. They look at the thickness of the same. There are so many other nutritional many parameters, but we won't go into the details. Now let's look at some liver diseases. If you look at liver diseases, see, you have paradoxes in the diet in liver disease. On one hand, you have obesity where you are restricting intake. On the other hand, you have cirrhosis where a patient is malnourished or emaciated and dietary intake is encouraged. Now look at the other paradox. On one hand, you have acute viral hepatitis where the family restricts deliberately and has dietary taboos. And on the other hand, there are metabolic liver diseases in which the nature deliberately restricts the intake of certain food items. If you look at cirrhosis, hypoalbuminemia, that is because of sarcopenia, poor muscle mass. It causes edema, ascites, hypocalcemia, bone loss. And the therapy for that will be a high protein diet, albumin and calcium. In cirrhosis, we will also have bile salt and fat deficiency, where there'll be weight loss, skin issues, night blindness, coagulopathy, and so many other things. You can get away with that by medium chain triglycerides, fat soluble and water soluble vitamins. Then you have high energy consumption in cirrhosis, and hence you require a carbohydrate-rich diet. Cirrhotics have other issues such as portal hypertension, where there is blood loss, and hence you will require to give hematinics, other than the other measures. Renal insufficiency, where you would require fluid restriction and sodium restriction. So hepatic encephalopathy, where there will be altered sodium, and hence you will need to give protein modifications or branch chain amino acids. So that means in a cirrhosis, there are too many things going on where the diet is altered. The American Association of Study of Liver Disease says that in a patient with hepatic encephalopathy, at the time of hepatic encephalopathy, you have to transiently reduce the protein in the diet to about 0.5 mg per kg. But the moment the hepatic encephalopathy has resolved, you should go back to the normal diet, and that is 1 to 1.5 grams per kg per day. If you look at the choice of protein, then the vegetable proteins are physiologically more acceptable than the animal protein. The vegetable-based proteins also have high fiber and a rich source of short-chain fatty acids, and that will give some calories. But the animal meat actually has sulfated amino acids, which are precursors to mercaptans and indoles, and they actually precipitate hepatic encephalopathy. So if you look at branch chain amino acids, you will see that the branch chain amino acids, there is an imbalance. The branch chain amino acids are the ones that are better than the aromatic amino acid, because the aromatic amino acids actually cause false neurotransmitters that cross the blood-brain barrier and cause hepatic encephalopathy. So, branch chain amino acids is one of the nutritional therapies in cirrhosis, where you give about 0.25 to zero point 0.5 grams per kg per day, but you restrict it to refractory cases of hepatic encephalopathy. You do not give it as a primary therapy in hepatic encephalopathy. If you look at ascites, then you all know that ascites, salt causes increase in ascites, and hence we must restrict the salt. So 1 gram of table salt contains about 17 milliequivalents of sodium, and you have to restrict it to 1 to 2 milliequivalents per day in an infant and 1 to 2 grams per day in an adolescent. These are some of the sodium in the dietary items which are contraindicated in cirrhotics. So you have table salt, sauces, breads, potato, chips, biscuits, cheese, and so many other things. But the natural items contain very little sodium. That means the ones that are vegetable and fruits contain little sodium. So they really do not cause increase in ascites. If you look at metabolic conditions which are unique to children and not to adults, you have to understand that metabolic conditions can occur at various levels. So the nutritional intervention is always targeted either to the ingestion, like galactosemia and fructosemia, or to an end product, like cornstarch therapy, where glucose is required. Or it can be to circumvent a toxic product, and that is like tyrosinemia. In addition to the supportive therapy, you have cholestasis, where you have medium chain triglycerides you give, Wilson's disease, where you have copper restrictions, ascites, salt, and hepatic encephalopathy, branch in amino acids. Now, if you look at specific liver disorders and dietary interventions, those disorders that are prevalent in India where we can have some kind of therapy that's possible in India, these are the ones that are there in terms of age. So galactosemia and the fatty acid oxygen defects are the ones that present in the first few years of life. Wilson's disease later in childhood. Glycogen storage disease anywhere from 1 year of age and above or even younger. And things like urea cycle defects and citrulline deficiency, which can be there at any point of time. But these are very rare disorders. We should not talk much about them. So let's talk about commoner disorders. Wilson's disease, there is no need for stringent copper-restricted diet, as it does not cause deterioration in the disease. You have to understand that till the time the chelation has taken place in full force, that 1 year of the first year of chelation is the time when copper restriction in the food items needs to be done. But once the chelation has properly set in and the drug has been started, thereafterwards, even if you eat a little bit of liver, shellfish, nuts, chocolates, and mushrooms, it's not really going to make much of a difference. So nuts, chocolate, and mushrooms, which children do eat, can be permitted thereafterwards. Drinking water should contain very little copper, and nowadays actually copper pipelines are very, very expensive and nobody uses them, so that's not a problem. So this is a collection of all the copper, high copper items and the low copper items from the Indian National Institute of Nutrition table. So as you can see, the red gram and the soya bean are possibly the only ones that contain very high copper in the edible item. The rest of them are very, very eaten in minute quantities. Your spices are eaten in so less quantities that really do not cause much of copper burden. Galactosemia in infants, lactose-free formulations you have, and galactosemia you have to understand is a disorder where the galactose is not metabolized, it becomes toxic and it kills the baby. Now, breast milk, formula milk, all kinds of animal milk are totally restricted in galactosemia, hence you have to give some kind of milk to the child. Obviously, these are going to be small babies. So you have 3-4 options. The first one is a non-lactose casein-based formula, but casein itself contains a lot of galactose, so you're not going to use. Second is to use a non-lactose soy-based formula, which contains very little galactose in India, and that is permissible, but there are some issues to the same. The best is to use a hydrolyzed formula where galactose is in negligible amounts. If you look at galactose-restricted diet in adults, and children, you have to understand that fruits and vegetables contribute very little galactose as compared to the endogenous galactose that the body itself produces. So the body itself brings about a lot of galactose that itself can be toxic. So the bound galactose is of possibly, we don't know the significance, but the free galactose is very important. And fruits and vegetables contain more of bound galactose than free galactose. So should we restrict fruits and vegetables? Well, there were studies that were done and it was shown that you have to take approximately 600 milligrams of galactose to have toxicity. To achieve that 600 milligrams of galactose, you need to eat 7 kg of apples, 2.5 kg of tomatoes, and 12 grams of peas, which is obviously, it is too much and you cannot eat that. Hence, restricting fruits and vegetables for galactose is not a good idea. If you look at glycogen storage disorders, the main ones that we see in a liver setup are type 1, 3, 4, 6, 9, and 11. 1 and 3 are the most important ones. 6, 9, 11, 6 and 9 are very mild and hence it does not really matter. But we'll talk about 3 and 1. Cornstarch therapy is the main problem. Actually, what happens is in this complex pathway, finally the glycogen is not being broken down to glucose. So the body is deficient of energy. So the end product, which is glucose, is not available. So now how do you circumvent this? You use cornstarch therapy. Cornstarch is containing a lot of complex kind of a carbohydrate. It's a starch, and it requires salivary and pancreatic amylases to break the alpha-1 and the alpha-1,6 and 1,4 bonds. And the brush border enzymes also do the same thing. Now, what you do is you give the starch in such a way that the glucose is released very slowly, sustained release of glucose into the body. To achieve that, it has to be an indigenously made cornstarch. That means you're not going to take the powder. You're going to take the maize and grind it into a form of something like suji. And that has to be uncooked, dissolved in cold water, because if you cook it or you put it in hot water, then the bonds, that is this complex alpha-1 and alpha-1,6 and 1,4 bonds will start breaking up. So the sustained release is gone. So you have to have it uncooked and dissolved in cold water. You can give it in the form of a continuous nasogastric drip with infusion pumps, and patients with refractory hypoglycemia, you require them to be given in the nighttime. But otherwise, majority, at least in type 3, can tolerate an intermittent oral feeding, and that is about 1.75 to 2.5 grams per kg per dose. The other dietary modifications is that you can also use a partially cooked starch in between snacks and during waking daytime and waking hours. GSD1 and GSD3, in GSD1, you cannot give even sucrose, but in GSD3, you can give sugar and milk. There is no restriction. But the problem in GSD3 is that there is muscle breakdown, and hence there will be hence there will be a protein intake of 3 grams per kg is almost required. The dietary therapy in hereditary fructose intolerance, what is allowed is glucose, powder, lactose, and everything else. What is not allowed, as you can understand, fructose is not going to be metabolized properly. So what is not going to be allowed is fruits, fruit juices, table sugar, and everything else that is going to contain a high degree of fructose. Hereditary fructose intolerance, remember, can cause both luminal and hepatic symptoms. Now let's come to the luminal disorders. Once again, if you look at how to intervene luminal disorders, you can target the ingestion. That means like celiac disease, where you want to give a gluten-free diet, or allergies like elimination diet, FODMAPs in IBS, which the next lecture will tell you, MCT, that is medium chain triglycerides in lymphangiectasia, or you can target an end result like Crohn's disease, where you give an exclusive enteral nutrition. There are some supportive therapies like GERD and eosinophilic esophagitis and functional constipation, where diet can make a difference. Now, if you look at, once again, all the disorders of diet in India, then celiac disease presents somewhere 1 year and above, irritable bowel syndrome later in the childhood. In the younger children, you have GERD and bovine milk allergy, which is cow's milk protein allergy. So let's look at GER, or gastroesophageal reflux. So the European Society recommends that we must give thickened feeds. That means if there is an infant who has this kind of an issue, which is becoming worse with time, what you can do is, other than the pharmacotherapy that you will give, you will also give thickened feeds, frequent small feeds, and there is a small role, a very, very minute role of using a hydrolyzed formula in this setup, but that is a very controversial uh, uh, thought. So what we usually do is we thicken the feed with a rice-based cereal, or you make frequent small feeds. In older children, you avoid bedtime snacks for decreasing the nocturnal reflux, and you again reduce the size of the meal, avoiding fats and chocolates. And in addition, you are also going to restrict a few items which you think can cause a lot of reflux, but these are not scientifically very well proven. But these are the items that stimulate gastric secretion and lower the pH of the esophagus and cause reflux. Celiac disease, the patient is intolerant to wheat, rye, and barley. Remember, rye is not available in India. Wheat and barley. Barley in India is rarely used, but in things like beer and all the other energy drinks, barley can be used. But a major problem is with the wheat. There is a growing celiac belt in India. Earlier, it was restricted to the northern parts of India, but then because of population mixing, it has spread almost everywhere. Now, all parts of India are reporting celiac disease. So the celiac belt is growing. What is the treatment of celiac disease? Gluten-free diet, which is strict, it's lifelong, and you have to stop wheat and barley and rye, and you are supposed to use the diet charts. Supportive treatment for 3 months include hematinics, multivitamins, and calcium. How does celiac disease, how does it work, the gluten-free diet? If you look at it, there are stepwise improvement. The moment you start the change in diet, you will see there's resolution of anemia, there's bone mineral density improves, generalized well-being, symptom resolution, weight gain, height gain, pubertal growth spurt, and long-term complications can be avoided. How to elicit compliance at follow-up? You have to ask child-centric questions. Allow the child to answer instead of the parent. Give them direct questions. Do you share tiffin in school? Does your friend mother make tasty parathas? So these are the ways you can get the answer out of a child. Okay, fine. The common mistakes and solutions, you have to understand the market paneer that is coming contains flour. So you have to make homemade paneer. The juices contain thickening agents. There are tinned products contain preservatives that contain gluten. And very, very important is that the chakki, the mixie, has to be indigenous to that household and not be a public chakki where other items are also being ground there. So these are the places where our patients have difficulties, so we tell them in advance. The compliance issues are going to be highest during puberty and when the child moves to a hostel or a mess where gluten-free diet cannot be ensured. Persistent diarrhea, dietary therapy is the cornerstone of management. And in that, you have a diet algorithm that is a low lactose diet, a lactose-free diet, hydrolyzed amino acid formula, and sometimes you may use a green banana diet. The green banana formulation is basically, the basis of it is that it's an amylase resistant starch. It's not digested in the human intestine. It's undelivered to the colon, and hence it forms short chain fatty acids, which increase the salt and water absorption, giving a trophic effect. How to prepare a green banana diet is you take some raw bananas, you put it in a pressure cooker, take the pulp out, add some rice and some oil and glucose in it and feed, and it gives about 54 calories per 100 ml. If you look at lactose intolerance, then lactose intolerance, you have to understand, is something that is superimposed with acute episodes of diarrhea. It can occur with chronic diarrheas or persistent diarrheas. The lactose in the diet is not metabolized by the lactase enzymes because the tips of the villi are denuded that enzyme is gone, hence the lactose is unabsorbed, goes down into the colon, changes itself by the bacteria into hydrogen and lactic acid, which gives rise to acidic and osmotic stools. And that is why you see a very reddened perineum, as you can see. And this redness increases up to the perianal area. So what you do in lactose intolerance, you take the child 2 to 3 weeks of lactose. The reason to say 2 to 3 weeks is because you want that villi to come back to normal. The denudation that has occurred, that has to come back to normal. The enzymes have to be replaced, and only then the patient will start tolerating lactose. Hence, 2 to 3 weeks. During that period, you can give soy feeds or low lactose feeds. You can continue to give breast feeds and also introduce complementary feeding. Nutrition in IBD, you have to understand, in IBD, there's a lot of protein energy malnutrition because of various reasons, malabsorption, pain, cytokines, and so many other things.
Dr. Moinak, can I interrupt?
Yes, ma'am.
I'm going for a meeting right now. It's something urgent, and I'll be back. So after you, Dr. Goshal will take up, and after that, Dr. Ashish will be. Yeah. So in the meanwhile, I think I should be back in half an hour.
Sure. Thank you. So if you look at nutrition in IBD, so most of the children have a very deficient target height. Now, one of the ways other than pharmacotherapy is to give an exclusive enteral nutrition. It's used as a first-line therapy in the West, and 85% achieve remission, and it has a steroid-sparing effect. With this exclusive enteral nutrition, what we do is we give only one type of diet all throughout to the child for the next 2 to 3 months. And it has a very good probiotic effect and immunomodulation and various other things. So what you can do is you can use a polymeric or a semi-elemental or an elemental formula, and studies have shown that there's no difference in efficacy of using the same. If you use an oral versus if you put a nasoenteric tube, the results are going to be the same. And you use it for a duration of 2 to 12 weeks. And these polymeric diets contain a lot of high protein and high calorie. A little bit about protein milk allergy, cow's milk protein allergy. Normally, the perfect setting is an infant who has colitis. You have recently started animal milk, and the child has developed symptoms of colitis after a month or two. There's a family history of allergies going on. When you put an endoscope into the rectum, you see such small aphthous ulcers, and then you take biopsy, you see a lot of eosinophils infiltrating. How do you manage? Well, one important thing you have to remember, and a strong message, is that all sorts of animal milk are the same. They contain the same amount of allergen. So a cow's milk, buffalo milk, goat milk, all contain a similar type of antigen. So if you've stopped cow's milk, you cannot introduce buffalo milk, okay? So you stop bovine milk and milk products, stop the formula feeds that are going to contain milk in it, continue breastfeeding. Above 6 months of age, you encourage solid feeds, and less than 6 months of age. Can you please mute yourself? Please mute yourself. Dr. Rohit Dhawan, please mute yourself. Okay, so you have special dietary formulations for when you have to use hydrolyzed formula. You have intact proteins, larger peptides, smaller peptides, and amino acids. As you break down the protein, the allergenicity is going to decrease, right? So with that thought, people have started using the extensively hydrolyzed formula, which is called the hyperlegenic formula, and there the response is 90%. And if you have intolerance to the extensively hydrolyzed formula, or if there's not been a benefit to the same, then we can use the amino acid formula, which is even smaller particles, and these are indicated if your extensive hydrolyzed formula has failed. Soy formulation, there's a lot of talk about soy, and it has 20% cross sensitivity to the bovine milk allergy, but that itself contains a lot of allergens, and these are not recommended less than 6 months of age, and they have long-term effects such as thyroid disorders and aluminum toxicity. Hence, Soy formulation less than 6 months of age, not allowed. How long should we restrict milk and milk products in bovine milk allergy? You have to remember this is a temporary phenomenon. It's not a long-term phenomenon. It's not a lifelong disease. So in non-Ig mediated, there are two types. One is Ig mediated and the non-Ig mediated. Ig mediated is the one that causes anaphylaxis the moment you touch milk to the body, and there you require longer. But most of what we see is non-Ig mediated. So about a year of restriction should be good enough. In functional constipation, other than pharmacotherapy, you have to remember that you have to give a good diet, which contains a lot of high fiber. And the way to calculate high fiber in the diet is age plus 5. The problem in India is the dietary intake is very poor in infants because they give a lot of milk to these babies, and hence you must advise the mother to decrease milk intake. Medium chain triglycerides is very important. Medium chain triglycerides are the ones that are directly absorbed into the portal system, but the long chain triglycerides are the ones that require the bile salts. So medium chain triglycerides do not require the help of bile salts to be absorbed into the body. And so in cases of cholestasis and cirrhosis, it's very, very important. And these are C6 to C10 carbon atoms. 1 gram of medium chain triglycerides oxidizes and gives about 8.3 calories, so which is very good for the body. There are some disorders that require MCT supplementation, such as intestinal lymphangiectasia, where it is the primary therapy of choice. And then there are supplementary, it is used as a supplement in neonatal cholestasis and cholestasis of infancy, such as primary familial intrahepatic cholestasis, and PILBD is paucity of interlobular bile ducts. These are difficult for you to understand, but basically cholestasis of infancy and neonatal cholestasis is used. It is also used in chylous ascites management and also in TPN in the intensive care and also in pancreatic diseases. Thank you very much.